Hi everyone, my name is Chloe and I am a last week third semester nursing school student in a BSN program, and I have decided to start filming some videos on some disease processes to help me review for my NCLEX, and because I love Nurse Sarah, love Nurse Mike, but sometimes I need like a layperson to understand, to like explain things to me. And then also sometimes I need a little bit more in-depth explanation on stuff. So yeah, we're gonna go over COPD first because that is what my next test is on. And I have made a a disease process map that I will leave linked below on my Etsy. And then I will leave the notes that I'm going over linked below as well. So let's get started. So COPD is chronic obstructive pulmonary disease. Sorry. Chronic obstructive pulmonary disease. And it is a chronic and progressive disease process with exacerbations as well. So the patho of it is like there's inflammation and it is just beating the lungs up. And it's related to chronic bronchitis or emphysema, and chronic bronchitis has to be bronchitis for 3 months or for more than 3 months over 2 years in a row. So this person has to be sick for real. And then emphysema is the alveoli septa become damaged and they merge into like a great room alveoli. So the alveoli are like this, and then in emphysema they go like this and they just merge together. So it's not covering as much surface area. And so this inflammation damages the alveoli. So the alveoli are usually like this, and the air is able to pass through pretty easily, the CO2 and O2. But then with the inflammation, they just become like this. They become gross. So like there's no surface area for that. Like air is not gonna pass through that. And so that leads to decreased oxygen and an increase in CO2, and they also have air trapping in their lungs, so that's what makes them have that barrel chest, that big like thing. So let's go over some of the risk factors. So the number one risk factor is smoking, and smoking is measured in pack years. So it's 1 pack per day equals a year. So like if a person is like, let's say a pack is about 20 cigarettes. So the patient's symptoms will start around 20 pack years of like smoking. And then another risk factor is breathing in toxins. So if you live in a place that's really polluted, then you're at risk. And then asthma, and that's related to the chronic bronchitis. So asthma will lead to chronic bronchitis, which leads to COPD. And then there's a thing called alpha-1 antitrypsin, and that's a blood test, and that's usually found in like kids. So usually the people that you're gonna get with COPD are gonna be like older people who have smoked every single day of their life. And yeah, but the alpha-1 antitrypsin is good to know because that could also come up on the NCLEX or something, or you could see a kid come in with COPD and you're like, what the heck? Like they're like 5, there's no way they've been smoking for 20 years. And it's the alpha-1 antitrypsin. Some of the complications due to COPD are right-sided heart failure related to the pulmonary hypertension. So pulmonary hypertension is the afterload on the right ventricle of the heart. And the afterload is just, it's getting tighter and tighter and tighter until it can't pump anymore because the lungs are just trapping so much air in. So the heart is just getting like, yeah, pretty great explanation. Most of your COPDers are also going to be chronic AFibers related to that pulmonary hypertension as well. So they'll probably be on a blood thinner, that kind of stuff. And they're going to be a little bit skinny and malnourished because they are working so hard to breathe. They're burning so many calories just breathing. They're going to be tired. Yeah. And they're going to be in respiratory acidosis related to that, holding on to that CO2. And then one of the complications is also vent dependence if they are placed on a ventilator. Some of the meds and treatments, let's go over those. So PPD is percussion and postural drainage. The respiratory therapist will do a lot of those, and they go to school for that. But basically, you're just gonna hit them pretty dang hard to like get that mucus just going, man. And then a surgery that could be possible, but they probably wouldn't be really good candidates for it, would be a lung resection or transplant, and that would probably be more indicated for those kids with the alpha-1 antitrypsin instead of like a 80-year-old lady who has smoked every single day of her life, that kind of thing. So some of the lifestyle changes that they can do is obviously quit smoking, and then some of the stuff that we're gonna do is put them on oxygen, 1 to 2 liters nasal cannula, and you want their SATs to be between 88 and 92, because if they are getting more oxygen, their drive of breathing is not driven by oxygen need, it's driven by CO2 need. So when they're getting more oxygen, their drive for breathing just goes down. So kind of sucks. And then some of the meds that we're gonna give them are IV push steroids, meter dose inhalers, so that's gonna be like albuterol, that kind of stuff, antibiotics, some bronchodilators, again albuterol, anxiolytics, so they're gonna have a lot of anxiety related to that like drive for breathing and like that panicky feeling, like it just feels like, oh my gosh, like I literally can't breathe. So they're gonna be on some anxiolytics, and then probably Coumadin related to the AFib, or like a blood thinner of some kind. I just wrote Coumadin. So some of the signs and symptoms of COPD, some of the like classic presentation signs are gonna be shortness of breath, duh, hypoxia, duh, because their drive for breathing is related to the CO2 in their body, not the oxygen in their body. Hypoxia is low oxygen. They're gonna have a barrel chest related to that air trapping. They're gonna have clubbed nails, and they're gonna have diminished heart and lung sounds, because it just is gonna sound empty in there because there's so much freaking air in there. And they're gonna have a high work of breathing, so they're gonna be tired. They're gonna be like breathing in like, it's gonna be hard for them, and they're probably gonna use a lot of accessory muscles to breathe. And yeah. Some of the diagnostic tests that you can expect for this patient are PFTs, and those are pulmonary function tests. And one of those is forced expiratory volume in 1 second over forced expiratory volume with no time limit. So it's gonna be really hard for them to get all of their air out in 1 second. So basically it's like, okay, I have 1 Mississippi to get this out. Ready? Over like no time limit. And then that is compared to a percentage of like what it should be for someone their age. And I think size has something to do with it, but I'm pretty sure it's age. And then the alpha-1 antitrypsin panel, and then capnography, that's gonna be the end tidal CO2 on like a vent and stuff. And then ABGs as well, and you'll probably be drawing frequent ABGs on this person, and they will most likely be acidotic. They are definitely going to be acidotic, let's be real here. Some of the nursing interventions and patient education that you're going to provide, so they are going to be staged on their COPD, and that's going to be based on their pulmonary function tests. So mild COPD is going to be more of like a dry cough and some sputum. Moderate COPD is going to be shortness of breath. They're going to have shortness of breath on exertion. Severe is going to be shortness of breath with their ADLs. And then very severe is going to be shortness of breath at rest. And for the severe and very severe, they're going to sleep in the recliner. Like they're going to be like, I literally cannot lie down. Like I am going to suffocate myself if I lie down. And then some of the stuff that we're going to provide to them are nutrition, hydration, no smoking education, anti-anxiety interventions, tissue management. We're going to keep the bed at high Fowlers. We're going to put them on no more than 1 to 2 liters of oxygen via nasal cannula. We're going to do pulse oximetry. We're going to have them in a calm environment. And then if they are on a vent, we are going to get them off ASAP. And then there's something that is called a turbowean for a vent, where they either do no CPAP trial or the world's shortest CPAP trial. And they do that because if they do a long CPAP trial like they usually do with patients, then they are going to use so much energy doing the CPAP trial that they're going to go into a respiratory code almost immediately after you extubate them. So it's better to just have the world's shortest CPAP trial for these patients. And obviously, it's not just like we extubate them. We will determine that on their SIMVs and like their tidal wave volumes and stuff like that. So speaking of ventilation, let's go over some vent settings. So some of the modes on the vent are AC, that is assist control, and that is mandatory breaths and also assisted breaths, and they're going to be at a set tidal volume. So basically at the set like mils of air that they can breathe in, basically. SIMV is synchronized intermittent mandatory ventilation, and that's going to be mandatory and the patient's spontaneous breaths. And they aren't going to have a set tidal volume for the spontaneous breaths, but they will have a set tidal volume for the mandatory breathing. CPAP is continuous positive airway pressure, and it's all going to be the patient's respirations, and it's just going to pump air into them like respiratory rate is how much they're breathing per minute. And respiratory rate, the higher the respiratory rate, the lower the CO2, and the lower the respiratory rate, the higher the CO2. So respiratory rate controls CO2. Tidal volume is how many mils of air are in, like, the patient is able to have. And it depends on the patient's size and their lung compliance. Like if they have the atelectasis, like the sticky lungs, then they obviously are going to have a lower tidal volume. And this one also controls CO2, and it depends on like how big their breasts are and how small their breasts are will control how much CO2 is in their body as well. And respiratory therapists go to school for this, of course, and they are going to be the ones to talk to the doctor about that kind of stuff. But if you don't have a respiratory therapist on staff, then you're the one. FiO2 is fraction of inspired oxygen, and that one controls oxygen. So the higher the FiO2, the higher the oxygen. And 0.22 is room air. So just remember that. Fun little fact. PEEP is positive end expiratory pressure, and that is what keeps the lungs open at the very end of the expiration. And the higher the PEEP, the more open the alveoli, and the higher the O2 levels. But something with PEEP is the higher the PEEP, the lower the blood pressure. So, okay, and PS is going to be pressure support. I just have that written on my vocab. NIFs are going to be negative inspiratory pressure, and that's basically how hard the patient is sucking down on that ET tube, like how hard they're doing that. PIPs, peak inspiratory pressure, and it's how hard the vent is pushing to get the air into the patient. So that's good. That's what you will hear when you hear the high pressure alarm going off on the vent. Now let's talk about the criteria for intubation for all patients, not necessarily just COPDers. So SATs are less than 84 with oxygen, probably with high flow, maybe even with a BiPAP. Trauma patients with an unstable airway, when you suspect that there's some laryngeal edema, we want to intubate them early. Low respirations at less than 6, and high respirations in the 30s. Obviously different for kids, but in the 30s. And then high CO2 in the ABG, and that's around 60. And COPDers might just live in the 50-50 club. Like I said, they're going to be acidotic. So we tolerate a lot more with the COPD patients. But a severe pH imbalance, like less than 7.2, is critical. Like we need to intubate them, we need to get control of that, and we need to get that pH like up. And then depressed LFC, so depressed level of consciousness. So if they're like unarousable, they don't know, yeah, that kind of stuff. Abdominal breathing, so using the accessory muscles to breathe. And then their eyeballs are saying impending doom. Like when you have someone who's literally like they cannot breathe, their eyeballs are gonna be like, help me, please. Oh, like I can't do this. So that's a sign that we're probably gonna intubate them, so they don't have to keep doing that. Now let's talk about some criteria for extubation. So good ABGs, obviously, so kind of like pH and CO2 within the normal limits. Spontaneous breathing, that'll be measured with the SIMV, and then if they have good tidal volumes as well, and that is measured with the SIMV ventilation mode. And the tidal volumes of the spontaneous breaths are around 400 mils. 400 mils are regular for females, like that's within the normal limit for females, and 500 is for males because males are gonna have bigger lungs than females. They're managing their secretions. They're not like choking on their spit and stuff. They're like able to like manage it. Like they're able to cough with the ET tube down. They're like no infection. They're hemodynamically stable, so they have pressure, they have a pulse. They have balanced electrolytes, so their sodium is not out of whack, or their potassium is not out of whack. And they've stabilized the underlying problem. And their pain is controlled, and they're off sedation. Okay, we've talked a lot about PFTs. Let's talk a little bit more about them. So the tidal volume is the air in and out with a normal cycle, the like volume of air. And again, that's around 400 mils for females, 500 mils for males. Inspiratory reserve volume is the air that you could breathe in, like the max amount of air that you could breathe in. Functional residual capacity is your residual and expiratory reserve. Your residual volume is the air that you can't breathe out, the air that is stuck in your lungs to keep those alveoli from being like and sticking together. Expiratory reserve volume is everything that you could possibly breathe out. So functional residual capacity is like the leftover air in your lungs. Inspiratory capacity is the max amount of air that you can breathe in after a normal breath. So that's tidal volume and inspiratory reserve volume. Vital capacity is the biggest breath in and out that you can possibly take ever. And total lung capacity is everything all put together in a nice, neat little bow. Thank you so much for watching, and like I said, those notes will be linked down below, and my concept disease map will be linked, and that's on my Etsy. Thank you guys so much. I'm so excited to start this. It'll be great for me to study for the NCLEX. I hope y'all enjoy. Thank you. Feel free to leave any questions or anything like that in the comments below, and I'll try to get to them. Obviously, I'm still a student, so if anything I say is wrong or if you have anything to add to it, please feel free to do so, because I'm gonna be totally honest with you. I don't know everything. I just don't. But this is the stuff that I have found to be most helpful for me, and this is the stuff that I have gone over in my lecture, and this is the stuff that I will be tested on. So please leave comments. Let's get it going.